Well, I'll start by introducing myself because obviously I'm not Liz. Um, I'm Rocky Wilkinson. I'm one of Liz's colleagues here at the Oxford Uehiro Centre for Practical Ethics, and it's my great pleasure to be hosting Bitesize this week and next week while Liz is having a much needed break. And it's wonderful to see so many of you here. Must admit, I've enjoyed being a participant the last couple of weeks along with all of you. A reminder that we are open to the public, and we want everyone to feel comfortable and safe here. So please remember to be polite and considerate of others in your comments and questions, but please don't let that hold you back. Also, topic of mental health and illness could potentially be triggering for some people. However, Anna has done her hardest work to ensure that this won't be the case, but we do just need to warn you before we start. And if there's anything that comes up, let us know. So without further ado, if no one has any questions, I would like to welcome Anna Golova, who's a second year DPhil student here at the Oxford Uehiro Centre, doing her DPhil on the philosophy of psychiatry with a focus on the relationship between mental illness and the authentic self. And it's a fascinating topic, and I'm really looking forward to hearing more about that from Anna. Just a reminder before I hand over to her that we are recording at the moment during the talk session, but I will be turning the recording off for the discussion session towards the end. I think that's everything. Anna, thank you. And I'll hand over to you.
Yeah, thank you so much, Rocky. Can you all hear me okay and see my slides okay?
Any thumbs up if anyone can, or a thumbs down if you can't?
Okay, great. Yeah, then
Lovely.
I'm going to start. Thank you all so much for being here. I really appreciate the opportunity to talk to you all about my research area. So, yeah, as Rocky said, I work in the philosophy of psychiatry and we'll talk to you about the ethics of mental health and illness today. Um, the goal of my talk is to introduce some of the ways in which philosophers think about and have thought about the concepts mental health and mental illness, as well as some ethical challenges that might arise from these concepts. And I appreciate Rocky already having given you a little content warning that there might be some sensitive topics, but I'll be treading quite carefully. But I will be at one point using depression and grief as an example. So I just ask you to be mindful of that. Okay, so the plan for today is I'm first going to cover some philosophers' attempts to define what mental illness even is. Then I'm going to talk about what might happen if we define it too broadly and might overdiagnose it as a consequence. And thirdly, I'm going to discuss some of the reasons why it might really matter how we define and diagnose mental illness, including I'm going to talk about one possible implication, which is a phenomenon called self-illness ambiguity, which is the phenomenon that I most focus on in my research. But before jumping into that discussion, I just want to provide you with a brief historical background for this debate. So, psychiatry has historically been facing a lot of criticisms, especially since the 1960s, under the heading of the so called anti psychiatry movement. So, one set of criticisms pertain to the idea that psychiatry might actually just be a means of social control of those who don't conform to certain societal expectations. And one example that shows that this criticism was really warranted was that, for instance, homosexuality was included as a mental disorder until as late as 1973. Another kind of criticism pertained to the idea that psychiatry might be medicalizing or pathologizing a lot of things that are actually problems of life. So basically, turning a lot of difficulties that we might all be facing into illnesses. And the most prominent voice behind that kind of criticism was Thomas Jasch, ironically, a psychiatrist himself, who said the following: mental illness is a myth whose function is to disguise and thus render more palatable the bitter pill of moral conflicts in human relations. So Josh would say that it's part of life to have difficulties, including between people, and to call some of these mental illness is kind of a convenient excuse to shrug off responsibility in some of these cases. Now, this kind of extreme position of denying the very existence of mental illness is luckily quite rare among philosophers, but philosophers do want to find better ways of defining what true mental illness is and better ways of distinguishing it from things that might indeed be problems of living. So, for instance, one debate that I'm going to touch on later is the distinction between depression and grief. So, when should we diagnose depression versus when should we say, well, this is a case of normal grief that's kind of sadly part of life. And you can see that one can maintain that there should be a distinction between grief and depression without denying the very existence of depression in the way that Thomas Jasch would have. Okay, so the question of how to define mental illness is usually discussed in philosophy under the heading of the so-called demarcation question. So demarcation in the sense of um, drawing a line between two things. In this case, drawing a line or distinguishing between between disorder and health. And I should probably say between disorder and non-disorder, because there's a separate debate about whether mental health is more than the absence of mental disorder. So I think you're all familiar with the ways in which mental health often gets talked about in popular discourse, including online, where it seems to be a much kind of broader notion than just not having mental illness. It seems to be encompassing a broader kind of range of things like taking care of yourself in certain ways and thriving. And that's not the kind of notion that I will focus on today. I will really focus on mental disorder and mental illness, which I, by the way, use interchangeably for the purposes of this talk, even though that again is a separate debate whether there's a difference between the two. Another interesting thing to note on the demarcation question is that it's actually not just a problem in psychiatry. It's also a problem in the wider philosophy of medicine. So I think there's sometimes the tendency to think that, well, in physical medicine with physical diseases, everything's really clear and well defined. We know what's what. And only once we turn to mental disorder, that's when things get muddy. But actually, even with physical diseases, it's not always clear how best to define them and which kind of conditions should fall into that category. And you see that, for instance, with the debate about whether obesity should be considered a disease, which I think has been newly sparked recently by the whole kind of attention to weight loss drugs like Ozempic. Okay, so if we turn to the question, what is a mental illness? There are different responses to this demarcation question depending on who or what one thinks gets to decide what a mental disorder, but also disorder more generally, is. And there are largely two camps here that I want to introduce to you, which are naturalists and normativists. So, naturalists think that nature decides. They really want to find value free, usually biological categories to define mental disorder. So, most often, this refers to some notion of biological function or dysfunction. So, the idea is that there's really something kind of wrong with or in the person. By contrast, sorry, that's a spoiler. By contrast, normativists think that to call something a disorder is a reflection of our values. So, particularly of which kinds of states we deem desirable versus which kinds of states do we deem undesirable. So, they don't think there is this notion of real disorder independent of any of our value judgments. And then there are some mixed accounts in between that combine both natural and value laden elements. And in the following, I want to start by presenting a normative account to you, so a value laden one. But then I hope to show you that even for naturalists, it's actually really difficult to define mental disorder without referring to any values or social norms. Okay, so starting with a normative account. Here is Rachel Cooper's normative account. As I said, the demarcation question is also a question in the wider philosophy of medicine, and you see that here, in that Rachel Cooper's account is actually also an account of what's a disorder or a disease more generally. So, on her view, a disease is a condition that is a bad thing to have, is such that we consider the afflicted person to have been unlucky, and that can potentially be medically treated. Now, there are various criticisms that have been raised against these kinds of accounts. So, for instance, Elseline Kingma points out that this last point, can potentially be medically treated, might be a bit of a catch-22 situation, because we might want to define what a disorder is in the first place to determine what should be the kinds of things that medicine should be dealing with. So it might be difficult to define it the other way around. And the other criticism that's often brought against normative accounts is that they tend to be over-inclusive. So basically, they they will include some conditions that we don't intuitively want to call diseases. So, for instance, on Rachel Cooper's account, unwanted pregnancy would count as a disease. And the question with these kinds of definitions is then always, should one bite the bullet and just accept that something like unwanted pregnancy will be a disease on this account? Or do we rather think we need to amend the definition to better align with our intuitions? So now moving on to a naturalist account of mental disorder, which is also a mixed account in some ways that I'm going to explain in just a moment. Here, the most prominent name is Jerome Wakefield, who came up with the so-called harmful dysfunction account of mental disorder. So on his harmful dysfunction account, a condition is a mental disorder if and only if the condition causes some harm or deprivation of benefit to the person, and it results from the inability of some mental mechanism to perform its natural function. So you can now see why Jerome Wakefield's account is mixed, because the harm part of the definition is the value bit, whereas the dysfunction part is the supposedly objective value-free bit. Now, what does Wakefield mean by natural function? Well, he thinks that that is what explains why the mental mechanism in question has been evolutionarily selected. That sounds quite abstract at this point, so let's turn to an example to see what exactly that could mean. So here's the example of depression. So Wakefield, for instance, thinks that we have a kind of loss response or sadness generating mechanism, and that's supposed to be how humans naturally respond to losses. And he thinks that has been evolutionarily selected for a number of functions, including, for instance, attracting social support. And when that mechanism works fine, then we just have normal sadness, which tends to be kind of proportionate and appropriate in response to the kind of loss that triggers it. By contrast, when the mechanism breaks down and that harms the person, only then we have a case of depression. And Wakefield thinks that that usually expresses itself in that the reaction is kind of disproportionate to the loss that has occurred. So an often, probably too often used example here is imagine someone who has a goldfish whom they love very much, and one day that goldfish passes away. Now, if that person is devastated at the death of the goldfish for months, then perhaps some might say that that's a kind of overreaction, or at least too long of a reaction to the loss that has occurred. Well, the problem with that for Wakefield's account is the question, how do we know that this person's sadness is caused by a dysfunction in their loss response mechanism? It seems that we don't really have independent evidence for that, apart from the value judgment that on some views they are overreacting to what has happened. And that's a problem for Wakefield's account insofar as then not just the kind of the harm bit of his account is value laden, but also how we find out about the dysfunction bit. So on that view, yeah, it's kind of value laden all the way through. And you can also imagine that this won't really allow for the objective demarcation that Wakefield wants to attain, because of course, who's to say what is an appropriate reaction to a given loss that occurs? I mean, what is the appropriate amount of love one should have for one's goldfish? Can we say anything general about that? This is, of course, a ridiculous example, but you can see the kind of problems that would occur for Wakefield's account and the problematic value judgments we would have to make. So yeah, here's an illustration, depression as overreaction. But Wakefield and his colleague Alan Horwitz, they argued in this book, The Loss of Sadness, that we label too many instances of normal sadness as depression. And I think that that's because we don't take the context into account and don't acknowledge that intense sadness can be a normal response in some cases. And this leads me to the issue of overdiagnosis. So the overdiagnosis is one of the reasons why we might think that finding a good answer to the demarcation question is quite important. And you see that worry expressed in this tweet. So this person says, mental health is important, but we are in danger of overdiagnosing mental health issues. It's okay to feel sad, confused, or nervous. Not everything is a condition. Educate yourselves to know the difference. So I hope if there's one thing you'll take away from this talk, it's that even if you do educate yourselves, it's really difficult to know the difference sometimes. And you might have seen this kind of overdiagnosis discussion online with respect to conditions like ADHD and autism recently. But I won't go into that today. I will rather stick with the example of depression and compare it to grief, which is a really helpful comparison case for the question of overdiagnosis. So consider this example. Mrs. R is a 63-year-old who lost her mother. Immediately after the loss, she started to have problems with restlessness, difficulty falling and staying asleep, depressed mood, loss of interest in her family, fatigue, guilty feelings about her past relationship with her mother, and low appetite. So, indeed, Mrs. R would meet many of the diagnostic criteria of depression as set out in the Diagnostic and Statistical Manual of Mental Disorders, or DSM for short, which is often considered the kind of Bible of psychiatry. And I've highlighted in bold here in the text the kind of symptoms that would correspond to diagnostic criteria of depression in DSM-5. So I say DSM-5 here because the question of whether we should diagnose Mrs. R with depression, even if we want to just consult the DSM, this question will depend on which edition of the DSM we consult. Because while this is the most recent version, there have been previous ones. So in the 4th edition of the DSM, there was actually a so-called bereavement exclusion to depression. So that exclusion said that clinicians shouldn't diagnose depression until at least 2 months after the bereavement had occurred. And um, and sorry, I was just saying something in the chat. So on that view, it would depend on how long has Mrs. R been experiencing these symptoms. If it's been less than 2 months, then according to the bereavement exclusion, we shouldn't diagnose her with depression. But actually, in the rest of the case vignette, it goes on to say that she's been experiencing these symptoms for 4 months. So even according to DSM-4, she would have been diagnosed with depression. Now, Horowitz and Wakefield, in the book that I mentioned, they wanted to expand this exclusion criterion. So they wanted to expand it to other losses beyond bereavement and to say that we shouldn't diagnose depression so long as the response is proportionate to the loss that has occurred. But interestingly, history or the DSM have actually gone the other way and have removed the bereavement exclusion altogether. So according to DSM-5, as Abrams says, now psychiatrists will no longer be advised to wait 2 months after a patient loses a loved one for the period of normal grief to pass to diagnose mental illness and prescribe antidepressants. So this is one of the issues that I'm really interested in discussing with you. Do you think that that's a problem? Is it a problem so long as, treatment, including antidepressants, might actually help Mrs. R, even if this was just a case of normal grief? So one move that some people make is to say, in the way that Derek Bolton does, normality isn't the point, harm is. So perhaps we should just focus on harm and distress experienced by the person rather than this kind of obsession with finding exactly the right demarcation. And I think that's a general question that one needs to ask in this demarcation debate is what's the kind of definition that we want? Do we want to make sure that it's kind of one that's really theoretically waterproof and will only include cases of true mental disorder? Or do we want instead to find a definition that will be most useful for treatment purposes and for ultimately for people themselves? And that leads me to the third part of my presentation, which is talking about possible effects of diagnosing mental illness. And this is one of the implications I want to discuss is so-called self-illness ambiguity, which, as I said, I focus on in my research. And I'm sure most of you won't have heard that term, but might have experienced something like it in thinking about some of the people maybe in their lives or people in the media. So take, for instance, this example of a person on Facebook who says, depression will have you mistreating people that mean the most to you. Now, imagine this person is your friend and she keeps failing to turn up to things that you wanted to do together. Now, you might know that she is diagnosed with depression, or you might see this on her Facebook timeline, and you might think, wait a minute, is it because of her depression that she behaves like this? Or is she just a bad friend? And is that behavior part of her personality or part of her illness? And where's the line between the two anyway? And of course, you can imagine that this person might ask herself a lot of these same questions in reflecting about her life and her relationships. So these kinds of questions are instances of what some philosophers call self-illness ambiguity. And it gets described in the literature as the difficulty in distinguishing oneself or who one is from a mental disorder or diagnosis, expressed in questions such as, if I experience X, is it because of the illness or is it just me? And as you saw in the previous example, this can also occur from a third person perspective. So you might wonder about someone else. Is this behavior attributable to them or to their mental disorder? So here are a few further examples of self-illness ambiguity that are often cited in the literature. So for instance, here is someone who's diagnosed with anorexia saying, am I being anorexic because I'm not having a spread? Or is that me being perfectly capable of making my own decision about what I do and don't like? Or you have this case, which I think is a woman whose husband is diagnosed with manic depression. She says, it's sometimes unclear whether the illness is talking or whether he is talking. And especially in these kind of third person contexts, I think questions become especially interesting for ethicists, especially once we invoke this for kind of asking which kind of behaviors the person is responsible for, and whether she's autonomous with respect to certain choices and actions. And that's the kind of questions that can come up in medical ethics too. So you can imagine that some clinicians or medical ethicists might ask, is this a treatment decision we should respect, or is that the person's mental illness talking? And in my research, I really hope to question that kind of separation between self and mental illness, and also to show that what you're going to say about the possibility of that separation really depends on how you define what a mental illness is, and of course, what the self is. But if you essentially take the kind of account of mental disorder that's put forward by the DSM, so you think of mental disorders primarily as these kind of symptom clusters that are basically descriptions of the person's experience, then it's really difficult to separate that from the person. And in that case, we would need a much more nuanced account of how mental illness can relate to people's agency and autonomy. And that's the kind of thing that I'm hoping to contribute in my research, to add some nuance to those kinds of debates about self-illness ambiguity and its possible ethical implications. So before we move to the discussion, where I'm really interested in hearing about your thoughts on diagnosis and other possible implications, I just want to flag some reading suggestions to you. So first, there are two general resources if you are interested in this area. So one is kind of always the recommendation to look to these Oxford handbooks. So the Oxford Handbook of Philosophy and Psychiatry is a really good and very exhaustive resource, so you do have to be selective. But one book that I would really recommend, actually, probably kind of first, if you want to learn more about this area, is Derek Bolton's book, What is Mental Disorder? That provides a really good overview over this philosophical debate and also its historical context. And then, if you want to learn more about self-illness ambiguity, I can recommend you read this special issue on self-illness ambiguity in the journal Philosophical Explorations. The special issue actually spans 3 issues of the journal, but you'll find it if you go to that editorial by the guest editors Dings and De Bruin. And there you'll also find Doug McConnell's and my paper, shameless plug, on self-illness ambiguity in the context of addiction, and several other papers by really great thinkers in this area, including Roy Dings, Sanneke de Haan, and also Sophia Jepson. Lots of very insightful things to read on this topic. And then finally, one thing that I didn't really get to go into today, but do want to just briefly mention, is that there have been a lot of developments recently in the philosophy of psychiatry, including questions like, should we call it philosophy of psychiatry? So there's been a lot of debate about what's the right kind of terminology to use, including moving away from terms like patients, and on some views also terms like mental illness and mental disorder, and focusing much more on the people who are using mental health services. So that's an interesting development, that the kind of critiques that I started my talk with, the anti-psychiatry movement, that was mostly psychiatrists criticizing psychiatry. But now the criticism mostly comes from people who use mental health services or have used them. And there's a really growing recognition that their voices need to be heard in this debate. So if you want to learn more about the background of those kinds of movements, I would recommend you read Mohammed Rashid's book, Madness and the Demand for Recognition. Then here's my email address. Feel free to reach out if you want to talk more about this. And finally, here are the rest of my references if you want to dive even deeper into this literature. But now I really look forward to discussing, further implications of diagnosis with you, beyond or perhaps including self-illness ambiguity. Thank you.